Okay. I would like to put this fourth poster as our World Blood Donor Day to encourage you to donate blood. And this is the way that my guideline can be really true, because we need blood at the blood bank. My learning objectives is the use of blood and blood products, red cells, fresh frozen plasma, platelets, cryoprecipitate. The guiding principles for transfusion is divided in general principle and indication. Transfusion of blood and blood components is a medical procedure and only can be prescribed and issued under the supervision of a medical doctor. A medical officer should be knowledgeable of indication, benefits, and risks associated to this procedure. The document of all the events that surrounding when we are administering blood have to be recorded in the recipient medical record. And always we will discuss with the patient any other alternative to blood and blood component. Indication of red blood cell. Red blood cell is indicated in order to achieve a fast increase of the supply of oxygen to the tissues when the concentration of hemoglobin is low and or the oxygen carrying capacity is reduced. So this condition is the one that will indicate if we have to transfuse a patient. Proper uses of the red blood cell. Treatment of symptomatic anemia. Prophylaxis of life-threatening anemia. Restoration of oxygen carrying capacity in case of hemorrhage. And this I have to call the attention that if somebody have a major bleeding, more than 30% of body weight, it could be on shock, and this is the moment that we have to transfuse. Other way to use red blood cell is through exchange transfusion in patient sickle cell disease and hyperbilirubinemia of the newborn. The other component of blood will be fresh frozen plasma, or FFP, and it will be used in patients that have any active bleeding as a result of multiple coagulation factor deficiency. Replacement in inherited factor deficiency when it's not available the concentrate factor. Clinically, significant bleeding in patients with liver disease. In case that we have a patient with massive transfusion, we will give blood, but also we have to give plasma in order to help to stop the bleeding. Disseminated intravascular coagulation. We have to treat the cause, but we have to support with FFP. When we have a patient under the therapy of warfarin, if the patient presented with severe bleeding, this is other indication of FFP. And in patients that have TTP, that we will do plasmapheresis. FFP is not indicated for coagulopathy that can be corrected with vitamin K, in patients with immunodeficiency, in patients that have been for wound healing, burns, to use it as a volume expansion to source nutrients, or to normalize abnormal coagulation when the patient is not bleeding. Indication of platelet. We will administer platelet when a patient has a bleeding due to critical decrease of platelet count, or when they functionally abnormal platelets. They have a platelet dysfunction. So these are the two conditions when we will give platelet transfusion. There are few recommendations that AABB and our guideline too, that we transfuse prophylactically platelets to reduce the risk of spontaneous bleeding when we have a patient with less than 10,000 platelet count and have a hypoproliferative disease. I can say when a patient is receiving treatment for leukemia or a patient with aplastic anemia. Prophylactically, we will have to give them platelet. We will have to give platelet to a patient that will require intervention of an elective central venous catheter, and the count of platelet is less than 20,000. When we're going to do a lumbar puncture, and if the platelet count is less than 50, there is another requirement to use platelet. If we're going to have a patient with a major surgery, it's necessary, with a count of less than 50, it's necessary to give them platelet. And in the case that we have patients that are going to be submitted to ophthalmic surgery, cardiac surgery, or neurosurgical surgery with less than 100,000, one of the recommendations is to give prophylactically platelet. Not to use platelet if there is not a life-threatening. When you have a patient with immunothrombocytopenia purpura, when you have a patient with thrombotic thrombocytopenia purpura, if you have a patient with syndrome of hemolysis with elevated liver function and low platelet count, HELLP syndrome, heparin-induced thrombocytopenia, or hyperesplenism. If there is not a life-threatening, you will have to treat the cause of that thrombocytopenia. Cryoprecipitate is prepared from FFP and is rich in factor VIII and fibrogen. Indication: hypofibrinogenemia, factor 13 deficiency, platelet dysfunction that unresponsible to DDAVP. When we have a patient with disseminated intravascular coagulation, in patients that have deficiency of factor VIII in absence of commercially prepared factor replacement, and in von Willebrand disease. Alternative to allogenic transfusion. This morning you could have it was advised that from 2003, National Blood Transfusion Service started with autologous donation and has been increasing year by year. And this is the opportunity to a patient donate his blood for the same intervention, and this reduces the risk of infectious disease. So we are increasing autologous donation with patients that are going to have scoliosis surgery, and patients that, in the case of prostate cancer or need to have any prostate procedure, the urologist will send them patient to the blood bank. I encourage, because this is another way that we can increase the patient have less risk to have any contamination, and it's a way that they can receive their own blood. Other alternative will be acute normovolemic hemodilution, and that will be done during the same intervention. The intervention, the surgical procedure, and will be done by the anesthesiology. And another way to utilize the red blood cells as a salvage treatment is in intraoperative surgical procedure. That blood can be reused in the patient again. Alternative to transfusion. It's very important to know, and when I was starting to my intervention, I was saying that you will treat the patient that have anemia, when you will give them blood when is the patient require or is affecting the oxygen level. There are other alternatives that you can increase the level of hemoglobin, and one of them is hematinic supplement. So you can treat your patient that is iron deficiency or vitamin B12 deficiency before they have the surgical procedure and you take it in the best condition. Another alternative to transfusion will be hematopoietic growth factors, that is the erythropoietin. For bleeding, we will have antifibrinolytic agents like tranexamic acid that will help to decrease the bleeding due to deficiency factors. Other ways that we can reduce the bleeding and can give an alternative to the patient will be a bloodless surgery, and that you will, the example will be laparoscopy. With laparoscopy, you will reduce the bleeding and the patient don't need to have any blood transfusion. Management of hypovolemic shock, that is the first management when we have a patient that have hemorrhage and is blood loss is less than 30%. And the way that we can increase is vital levels is, well, using fluid as normal saline, lactate ringers, and other dextran, and other volume expander. With this, I finish my presentation. Thank you.